talking about eyelid tumors. So basically, many a times we get certain patients in our OPDs which come with eyelid swellings, bumps, and we are not really sure what it is. And it's quite common case even with us. After seeing so many lesions, there are times that we are not really sure what we are dealing with. So what I've compiled here is a series of just cases. There is no theory about it. It's just about cases, identifying them, some key points, and how to proceed when we see a situation like that where there is a dilemma, and some common examples in some cases where a tumor may appear slightly differently than what we expect a tumor to be. Now, this 45-year-old gentleman came to the OPD with a very soft, rubbery kind of a mass over the lateral part of the upper eyelid. It was really soft to feel and had a rubbery consistency to it, causing the eyelid to have mechanical ptosis on that side and also an S-shaped deformity. There was also some subtle loss of eyelashes on the part involved. Anybody wants to guess what it could be? Okay. Took out the entire lesion, and the histopathologist told me that it's a neurofibroma. So what you need to see here in a neurofibroma, specifically I mentioned a rubbery type of feel. It's just giving a soft feel, rubbery feel, and granular kind of feel. That's what you get in a neurofibroma. An S-shaped deformity is kind of typically described in textbooks for neurofibromatosis and for dacryoadenitis being the other thing. But in dacryoadenitis, you will have a lot of inflammation associated with it. Here, there are no inflammatory signs. This lady presented with a small cystic swelling on the lateral aspect of the lower eyelid and wanted this cyst to be removed. Now, here we need to be really sure what we are dealing with. Are we dealing with just a simple epithelial kind of a cyst which is easy to take out in 15 minutes, or could there be something more to it? So I asked her to pinch her nose and perform a Valsalva maneuver, and you can see that on performing the Valsalva maneuver, the cyst size increased. So what does that indicate? That indicates that there is some communication with deeper vessels, and with building up of pressure in the superior part of the head, the vessel gets more blood and it gets filled up. Now you won't like to do this surgery as a simple cyst that you would remove, because otherwise you will encounter a lot of bleeding. And the other thing is, when the patient lies down, this cyst may even disappear. So you may not even find the cyst when the patient lies down on the table, and you may be in an embarrassing situation as to where the cyst has gone, what to remove. So we've got a new technique to deal with this kind of a problem, and what we do is we occlude the feeder vessel that if there is any, which we can see manually, we press that feeder vessel, we block it, and then we inject cyanoacrylate glue into the cyst, which makes the malformation a little hard and easier to excise. And then this malformation was excised completely after injecting the glue, and what you see here is the post-operative picture. Now this young lady, 24-year-old, came for cosmesis, said that she's having some redness on the upper eyelid for the last 6 months, which has become more prominent, and you could see some abnormal blood vessels are there. Now one option is that I could have gone and removed it entirely. That is something which I was thinking of when I first saw the patient, but then there is, as we always say, that there is no substitute for a complete examination. When I asked her to open the eyelid and manually pulled up the eyelid, I saw there was a deeper extension also. Valsalva was positive, so this patient actually was not just a patient of a small localized eyelid hemangioma, but actually a deep orbital varix, which also had a component in the eyelid. Now, you would not like to touch upon such a patient like any other simple eyelid mass, because you are likely to have a lot of hemorrhage there and bleeding problems. So I left this patient alone and did not operate on this patient. This old man, father of a brigadier in army, 65-year-old, came to me with a small lesion here, which was sort of a nodular lesion on the eyelid margin, more so on the internal margin, and also involving the meibomian glands. And I thought it could be something suspicious. I advised him immediate excision. He went to some local homeopath who said that there is nothing wrong with your eyelid and I'll give you this medicine, you will be okay in 15 days time. So he didn't come back to me for surgery. Instead, he went to that homeopath. He was the father of a brigadier, even a very well educated and a good family. And still these things do happen there. He came back to me after about a month and the lesion had almost doubled in size. And that's when I called his son to me and then I advised him that, he really needs a surgery. And so I excised the lesion completely. It turned out to be sebaceous gland carcinoma. And that's not a surprise. Now, the points to see here are the lid margin is distorted in this part where you see. You cannot see meibomian gland orifices normally. It's coming from these meibomian gland orifices. There are a lot of intrinsic vessels there in this lesion. So try to look for vessels in high magnification of your slit lamp, and there are internal vessels, distortion of lid margin architecture, no pain, suggests that you are dealing with something else, especially when the patient is elderly. Now this patient came for chalazion surgery, referred from some government hospital, came with a permission also for chalazion surgery that, you do my surgery immediately. But then there was something abnormal about this. Now, do you really see chalazions like this? It's such an elongated chalazion which is extending beyond the superior edge of tarsal plate on one side and beyond the inferior edge of tarsal plate on the other side. So, it's always useful when you are going for a chalazion, before going into the OT, just evert the eyelid when you are in the OPD, and there you see it's not a typical chalazion. What do you see here? It's a multinodular kind of a thing. There are multiple yellowish nodules there. That's because of the lipid content of the tumor. And there are a lot of vessels there. You see this whole part is red and there are a lot of intrinsic vessels to this lesion. Plus the lesion being extending above the tarsus, below the tarsus. A chalazion does not behave in this manner. So the diagnosis here was again a sebaceous gland carcinoma. This was again a 50-year-old male. As the age grows, we become more suspicious for tumors. Another patient who complained of 6-month history of irritation, redness in the eye, complained of profuse watering and discharge, presented with a lid swelling. On the surface, it looked like, okay, fine, maybe an innocuous granuloma, maybe a chalazion, could be. But unless and there was, the atypical thing was there was some blood spotting there on the lower eyelid margin, if you could see. And that prompted me to evert his eyelid, and what I saw surprised me. So this patient had a huge mass encompassing almost the entire horizontal expanse of the upper eyelid from the medial canthus to the lower lateral canthus, entire tarsal plate involved in a papillary form fashion, with a lot of vascularity, with bleeding happening on touching. So this is a red flag. Now this is not a simple chalazion, and the cause of irritation and discharge obviously will not go away with routine antibiotics and lubricants. This patient also was a patient of sebaceous gland carcinoma, but of a typical variant which we call as a pagetoid variant. In pagetoid variant, what happens is that the tumor just spreads over the surface like a flat lesion, doesn't penetrate too deep, but the horizontal expanse is much more than its vertical depth into the tissues. Another patient being treated for a long time for blepharitis. Patient was 79-year-old and had this kind of blepharitis only in one eye. So what would you expect and what do you see here? Note that the lid margin architecture was all distorted. The meibomian gland orifices are all destroyed. The lashes are typically absent. And somebody had even attempted a biopsy from here, suspecting a tumor, and that biopsy had revealed inflammatory cells. The reason being, the biopsy was taken probably too superficially and too less a material was given to the pathologist. So that also gives us a lesson that, a very small superficial biopsy may not work. Now, with this kind of a picture, it's more likely to be a sebaceous gland carcinoma when all the meibomian orifices are involved, when the lid margin architecture is distorted, and on histopathology this turned out to be a pagetoid sebaceous gland carcinoma. This is the epithelium, surface epithelium of the eyelid, and this is the tumor which is growing under the epithelium. This is the stroma, so it's not penetrating deep into the stroma, but just above the stroma, under the epithelium, it's spreading like a sheet of tumor cells. Another patient who came with a burst chalazion, he gave a history that he had a nodule here which burst out, leaving a lot of discharge and necrotic material. But you can see the irregularity and the solid nature of the lesion. Now this is a typical sebaceous gland carcinoma, but in our country, such typical presentation is usually very rare, and the atypical presentations are rather the norm. This patient had a history of some lesion which was excised somewhere long time back, again developed some sort of a solidification of the eyelid margin, and here obviously your diagnosis becomes a little quicker. You do suspect tumors more often once there is a history of some prior surgery, and many times our patients come from periphery where exact details are not even available with them. So we should always be cautious towards these entities whenever we see these patients. Now a 70-year-old female lady came again under treatment for ulcerative blepharitis for a long time. I don't blame anybody for considering this patient as having ulcerative blepharitis. That would be the initial diagnosis for most of us maybe. Patient had ulceration over the lid margin. Now the point here to see is that it's a unilateral problem in a patient who is elderly. There is ulceration of the lid margin, there is distortion of the margin, there are no glands which are seen, and the lashes are absent. All these things point towards a certain diagnosis. Now what does this look like? What could this be? Any guesses? Sorry? Yes. So this is a variant of basal cell carcinoma. What we've been taught in textbooks is not the basal cell carcinoma, the rolled in edges, the thick mass which penetrates deep. Now that is not that you'll always get. So there will be a variety of presentations that will come. Another patient came with a problem of irritation, chronic irritation, no other symptom, no pain. You can see the thickening here over the lateral part of the upper eyelid with some pigmentation of the lid margin here, and please note carefully that the lashes are absent here. Again, same problem. This also is basal cell carcinoma. A biopsy was done which confirmed the diagnosis. In any elderly patient with a unilateral problem where you can't really justify it or does not respond to usual treatment, suspect the unusual. Another patient, what you see here is a lid margin defect, the lid margin irregularity, pigmentation on the surface, loss of complete loss of lashes over this part, even involvement of a part of upper eyelid, the lateral canthus is involved. A second patient presenting with an ulcerative kind of a lesion just below the lid margin, deeply pigmented. What could this be? This one and this one. What do you suspect? Both of these are basal cell carcinomas. So basal cell carcinomas can also present with a lot of irregular pigmentation. Now this is the type of picture that we were taught in textbooks. An ulcerated kind of a lesion with rolled in edges which goes deep. This is a very small basal cell carcinoma, typical. Now another patient who presented with a chronic history of ulcerative blepharitis, and here you see a lot of inflammation also happening on the eyelid margin. Now what would you call this? Is it an ulcerative blepharitis? So again you see, look for the basic factors, points that I just mentioned. Is the lid margin architecture intact? Are the eyelashes intact? Are the meibomian gland orifices visible? Is there any vascularity abnormal? So look for all these features. So none of these features there. And with this lesion, there is an inflammatory component also along with this, what you see as inflammation. Now this is a specific variant of basal cell carcinoma, what we call as morphiiform variant or sclerosing variant of basal cell carcinoma. It spreads much beyond what you clinically see. Another patient wherein the upper eyelid, the lower eyelid, the eyeball even, and the lateral canthus were all destroyed. On a scan, this lesion was extending up to the maxillary sinus also. Needed a radical surgery. Now suppose if this patient had been picked up somewhere when the lesion was still small, maybe this patient's eye would have been salvaged. Maybe this patient did not have to undergo so much of morbidity after surgery that she would now undergo. Now this patient had just this history of chronic irritation, discharge. Again, many patients we see in our OPD, and in busy OPD there is not enough time to really evert the eyelid and have a look inside. But I strongly suggest patients who are giving chronic history, it's very useful. It just takes a minute to just flip the eyelid and look what's underneath. This patient presented with a papilliform mass over the tarsal conjunctiva, over the tarsal palpebral conjunctiva, growing in a frond-like fashion. What do you think it is? Is it a allergic component, allergic phenomena. There are a lot of intrinsic vessels there. It's even bleeding on eversion. This was a squamous cell carcinoma. In our country, sebaceous gland carcinoma is the most common, followed probably by basal cell carcinoma and then squamous cell carcinoma over the eyelid. Another patient who said that he had a small nevus on the eyelid which spread within the past 1 month or so. Patient's age was 65 years old, giving a history that a nevus has spread should alert you to something more. Now this patient on biopsy turned out to be lentigo maligna. He had a flat patch of pigmentation, deep dark pigmentation on the eyelid. Now this is a pre-malignant condition. It's not exactly melanoma right away, but it's a pre-malignant condition with high chances of it converting into melanoma. Now this is how it looks when it converts into melanoma. Another patient coming with a soft rubbery mass, pinkish in color, hanging from the upper eyelid. What does this look like? Okay, because it seemed to me a little more than just an eyelid mass, I got a scan done, and on scan it was visible that the mass was there bilaterally. It was not just in the affected eye, but it was there in the other eye also. And biopsy confirmed the diagnosis of lymphoma. You can see sheets of monomorphic tumor cells. This is a lymphoma. If it's a bilateral lymphoma, you do chemotherapy. If it's a unilateral, it's more chances are that he'll do well with radiation as well. Another patient with a lymphoma presenting with just unilateral involvement of upper and lower eyelid. Now this patient was, there is no characteristic feature of a tumor here. This patient just gave a history of a recurrence of chalazion after 3 surgeries earlier. So I just decided to treat it like chalazion and just send the material for histopathology. To my surprise and the pathologist's surprise as well, it turned out to be an adenoid cystic carcinoma, which is an extremely rare tumor of the eyelid. So it was excised in completely, and the recurrences are generally not there, fortunately. Another patient who came for removal of cyst because he was going for a daughter's marriage, wanted it to be done for cosmetic reasons, but you see very prominent blood vessels here. It's a solid cystic kind of a lesion. Again, so because of the vascularity here, abnormal vascularity, and slight sparsity of lashes here, decided to excise it completely rather than just treat it like a cyst. And to our surprise, it again turned out to be a very unusual tumor of the eyelid. That's a sweat gland carcinoma. Another patient who presented to me, again giving a history of chalazion surgery done thrice earlier, but every time the surgery was done, the tumor would come back bigger. So complete excision was done, a rubbery soft mass, rather ill-defined, having a lot of vascularity. It turned out to be eyelid myxoma. Now, if there is a patient with myxoma of the eyelid or conjunctiva, you need to rule out a cardiac myxoma as well. So, got the echo done. Echo was normal. That's a part of Carney's complex. So, just going on to the management protocol now. So if you have a diffuse lesion where the diagnosis is uncertain, and if you feel that it's a tumor, then you would rather need a very radical surgery. It's better do a small incisional biopsy, but it better be full thickness or take sufficient amount of the representative material. It's a well-defined lesion. The dictum is that you excise the lesion completely with some clear margins and don't leave behind any residue. A margin of about 4 mm on either side is sufficient. MAP biopsies are indicated when you have a lesion like what I showed you, pagetoid sebaceous gland carcinoma or diffuse acquired melanosis of the conjunctiva. That's where you require MAP biopsy. You take small bits from the uninvolved segments also. And then you need to plan your reconstruction based on the kind of defect that you are likely to have. So this patient was treated with Cutler beard, another patient was treated with Hughes tarsoconjunctival flap. You need to plan all this. So I'm not going into surgical details because this session is mainly about identification. And this patient was dealt with by Tenzels. So just to conclude that these tumors can have a wide variety of presentations and always conduct a thorough examination. Have a very low threshold of biopsy whenever in doubt. And timely treatment can not only be eye saving but life saving for these patients. Thank you.